So thank you all very much for the opportunity to speak today. I have no disclosures beyond the grants that fund my work as listed here, and the ADAPT study in particular is funded by the Alzheimer's Research UK Blood Biomarker Challenge. I'm also a executive committee member of the co-chair of the Real World Translation Work Group of ISTART in the Alzheimer's Association. In this talk, I'll first seek to give a bit of background on why blood tests for Alzheimer's disease might be useful and in what contexts. I'll briefly cover what the current top candidate tests are likely to be indicating and proceed to considering what needs to be done in order to get them into routine use in the NHS. I'll then talk to you about a new study that will seek to provide the level of evidence that we've needed to get blood tests for Alzheimer's disease into the standard of care, the ADAPT study. So why does it matter whether or not we know what dementia subtype a person has? Getting an accurate diagnosis of Alzheimer's disease is already very important right now because it allows for symptomatic treatments that are currently licensed and approved for use in the NHS to be prescribed. It also means that appropriate support can be put in place for individuals, and it allows patients and their families to plan and to access appropriate research studies. The imminent arrival of new treatments, which can clear some of the toxic proteins that cause Alzheimer's disease and have been making the news recently, makes the accurate diagnosis of Alzheimer's even more vital, as these treatments will only be appropriate for selected patients proven to have Alzheimer proteins within their brains early in the illness course. However, based on the sort of standard assessment that's undertaken in most memory clinics at the moment, if you are diagnosed with Alzheimer's disease, there's about a 30% chance the diagnosis will be wrong. Conversely, some people will be told that they do not have Alzheimer's disease, but they do actually have the condition. While most people in memory clinics have access to either CT scans or MRI scans, which should demonstrate patterns of shrinkage of various brain areas, these scans cannot tell us whether Alzheimer's-related proteins, amyloid and tau, are present and likely to be causing those shrinkage patterns. The fact is that we do actually have reliable ways of detecting these proteins in the brain, but currently about only 4% of those who attend a memory clinic in the UK have access to these. And that's because these methods are either highly specialized amyloid PET scans, which involve radioactivity and are expensive, or lumbar punctures, which are invasive and require significant staff upskilling and logistical arrangements. If we were able to detect the proteins through blood tests instead, we'd potentially diagnose many more people with Alzheimer's more specifically, more cheaply, and likely earlier than they would otherwise receive diagnostic confirmation. The good news is that we can actually detect such blood biomarkers. The first indications of a valid blood biomarker of the amyloid pathology were provided by seminal work by groups at Washington University and in Japan, who developed methods based on mass spectrometry for measuring amyloid beta peptides in plasma. They showed that the ratio of plasma amyloid beta 42 to amyloid beta 40 is able to distinguish individuals who are amyloid PET positive from those who are PET negative. And the Washington University assay has gone on to become the first FDA-approved plasma Alzheimer's disease biomarker test for clinical application. However, mass spectrometric assays are probably not that easy to generalize to settings such as the NHS for the kind of volume of testing that would be required for diagnosis in Alzheimer's disease. So the good news is that there's also now, since the last few years, the development of technological advances in immunoassay platforms, which have brought them down to a sensitivity of the femtomolar range, which is equivalent of finding 1 grain of salt in an Olympic-sized swimming pool. Two of the platforms that we use at UCL are here. The Simoa platform on the left, which is a partially automated platform, and the LumaPulse, which is a fully automated platform. In addition to plasma biomarkers of amyloid, the field has also grown with the advent of plasma assays for phosphorylated tau, tau being the other protein hallmark of Alzheimer's disease in the brain. In the Mayo Clinic study of aging, assays for phosphorylated tau217 associated with increased amyloid PET signal, increased entorhinal tau cortical PET signal, and reduced Alzheimer's disease signature region cortical thickness in the temporal lobe, which is what is thought to mediate the memory symptoms in Alzheimer's disease. This is confirmed in 4 cohorts using a different single molecular array assay, the Simoa technology that I showed you on the previous slide for phospho-tau217. And as you can see on the right here, the Canadian triad cohort showed that this phospho-tau217 biomarker increased with disease staging from normal cognition through mild cognitive impairment to Alzheimer's disease. However, soon after the findings on phospho-tau217 was discovered another biomarker called phospho-tau217. Here in the Swedish biofinder cohort, we can see that it demonstrated a good correlation between the antemortem plasma p-tau217 value and the load of amyloid of tau tangle pathology in the brain in Alzheimer's disease, but not in other dementias. And over here, we can see that it showed a slight superiority over p-tau181 for distinguishing neuropathologically confirmed Alzheimer's disease from frontotemporal lobar degeneration. So what are the steps for bringing blood biomarkers for Alzheimer's to the clinic? We can think of this in 5 stages. The first, which establishes their rationale and which I discussed at the start of the talk, is achieved. The second stage is to look at how they discriminate between individuals who are defined clearly with gold standard biomarkers with disease and control, and I've shown you that in the previous slides. The third is to look at the detection of prodromal disease and prediction of progression, and a lot of evidence has been coming out on that recently. The fourth and fifth stages are the ones where the real evidence needs to be generated now, and that is to see how the blood test works in settings such as primary care and memory clinics when the testing is done in real time rather than all in one batch. And then to generate evidence for adoption into routine clinical practice, we need to show that it actually impacts disease-related outcomes and is cost-effective. So the issues that have to be addressed include in what context of use the blood test would be used, what pre-analytical factors may affect its interpretation, what cut points we would adopt in order to assign people as having an abnormal or normal result, for example, and to ensure that the research includes hitherto underrepresented populations when we generate those cut points as well as when we apply them. And finally, when we come to the point of giving individual patients their results, there are ethical implications of how to deliver that molecular-assisted diagnosis to the patient. And particularly, and this is probably coming not very long from now, there would be direct-to-consumer testing, which can become a reality in the way that genetic testing has through 23andMe, for example, where the result actually has lots of implications for the patient, but it isn't necessarily being delivered in a supported way. So in terms of context of use, there are broadly 4 contexts. And the first one is to confirm the presence of Alzheimer's disease in symptomatic individuals who already have either mild cognitive impairment or dementia. The second is to predict progression from mild cognitive impairment to dementia or to predict functional decline in dementia and stratify people so that they can be selected for clinical trials. The third is to use a biomarker as a response variable when assessing the efficacy of potential clinical trial medications. And the fourth is to use the biomarker in screening the asymptomatic population. And that's, of course, the most controversial, but perhaps the area in which most people are most excited to see developments in these blood biomarkers. I'm going to focus today on the first context of use, which is diagnosis in symptomatic individuals and how a blood biomarker test could actually influence clinician behavior. So an example here is from a study that was done on a plasma amyloid beta 42-40 test, incorporated also with an algorithm that includes the ApoE genotype and age, called the PrecivityAD algorithm, which is in current clinical use in the US. And this study here showed that prior to getting the results of a blood test, most clinicians who were diagnosing Alzheimer's disease tended towards the mean. So they assigned their own confidence in their diagnosis of Alzheimer's disease somewhere to the middle. But when the blood test was then applied and they were given a result, their confidence immediately went either strongly in favor of the probability of Alzheimer's disease or strongly against it. And what was interesting there is that this actually changed their behavior in terms of prescribing Alzheimer's disease drugs. So you can see that people who had a low post-test probability had a lot of deprescription of Alzheimer's disease drugs. People who had a high post-test probability had a lot of increase in prescription of Alzheimer's disease drugs. And overall, this resulted in increased percentages of diagnosis of Alzheimer's disease and increased prescriptions of medications by about 10%. When we choose a clinical biomarker, however, it's important to consider how robust it's going to be when it goes into the real world setting. And there are two, you can think of it as a sort of balance in 2 scales, really. On one side, we have the biomarker's effect size. How much is it different, or usually it's an increase? How much is it increased in your population of interest, such as Alzheimer's disease, in comparison to others, such as people who don't have Alzheimer's disease in a memory clinic. And that's influenced mainly by the properties of the assay and then the stage of the disease. Usually you expect the biomarker to go up and be higher in more advanced stages for those biomarkers that track progression. However, what tips the scales away and makes assays less clinically robust is increased total measurement variability. And that can be influenced by pre-analytical factors, such as how badly a sample is mishandled or variations in how it is sampled and transported, analytical factors such as batch-to-batch variation in reagents, and drifts in assay performance over time, and also factors that can vary according to the individuals from whom the sample is taken, ranging from temporary things like the time of the day or their hydration status or their fasting status, and more intrinsic issues like demographic factors and comorbidities. So we did a study looking at comparing all of the available at the time phospho-tau assays in plasma that were commercially available in a round-robin study that was sponsored by the Alzheimer's Association Global Biomarkers Standardization Consortium. We provided samples from the Wilson CSF cohort at UCL, in which individuals have a gold standard diagnosis established by CSF testing through lumbar punctures. And we sent our samples all the way around to different labs and different assay developers to give a total of 31 individual phospho-tau measurements, which included 181, 205, 212, 217, and 231 as shown here. And you can see that consistently, the p-tau217 biomarkers had the highest fold change. You can see all of the top 10 biomarkers essentially are in the green, phospho-tau217. And the fold changes approached between 5 and 6 for the best performing ones. So you can see clearly here that if we're choosing amongst the phospho-taus, it looks like phospho-tau217 on grounds of fold change would be the best. But also we need to consider factors that may introduce that intra-individual variation I was talking about and tip the scale in the other direction. And one example I'm going to give you here is renal function. You can see in this study here by Michelle Mielke and the Mayo Clinic study of aging, that they were able to show that the impact of chronic kidney disease, which is in the middle of the slide here, actually for phospho-tau181 has a similar similar degree of association to having the presence of amyloid beta pathology in the brain. Whereas for phospho-tau217, the amyloid beta pathology effect size is much higher than that of kidney disease on that biomarker. So clearly there is still a significant effect, and we would need to consider the impact of kidney disease whenever we're measuring phospho-tau217. But there may actually be a way of getting around it, which has been something that's been demonstrated by those working on the Biofinder cohort in Sweden, which is that if we can measure the phospho-tau217 in relation to the total tau217 present in blood and take a ratio, we could in some ways control for the extent to which creatinine is being cleared and kidney function is influencing the phospho-tau217 level. So they were able to show that if you take a ratio between phospho-tau217 and total tau217, the association with the kidney disease actually reduces, the kidney impairment. So now that I've given you some background on plasma phospho-tau217 and the rationale for why we're interested in studying that in the real-world setting, I'll go on to describe our plans for our recently funded study, which is ADAPT. This, as I said, was being funded by the Alzheimer's Research UK Blood Biomarker Challenge Grant, and the co-primary investigators are myself and Professor Jonathan Schott at UCL. We will seek to establish plasma phospho-tau217 as a widely available NHS test and demonstrate its utility and its cost-effectiveness in real-life NHS memory clinics across the UK, thus providing the evidence sufficient to apply for MHRA licensing and NICE approval for integration of this test into the standard of care. We will be carrying out the ADAPT study in 3 stages. And the first of this is stage 1, which is actually underway now, which is the stage that allows us to derive the cut points and an interpretation tool that we will develop in relation to the gold standard of cerebrospinal fluid, as well as amyloid PET in collaboration with our colleagues at Imperial College. So we're taking advantage here of a biobank, 2 biobanks effectively of samples where we have paired cerebrospinal fluid and blood or paired amyloid PET and blood at Imperial. And we'll be deriving this interpretation tool to allow us to effectively categorize individuals as having either a positive blood test, an intermediate value, which is a gray zone that we will pre-specify at being between 15 to 20% of individuals, or a negative blood test. And this will allow us to then apply for MHRA approval for the use of this blood test in the third stage of our study, which is a randomized control trial. The second stage will allow us to do some ongoing validation of the cut points to ensure that they will not drift over time. And that will be through samples sent from Imperial College in real time to us at UCL to continue testing over the period of about 2 years. And the third stage is a randomized control trial, a quite novel design when it comes to the testing of a blood test, in which we will be embedding our trial in about 20 memory clinics across the clinical research network in the UK. This will involve the primary intervention will be the early versus late disclosure of the p-tau217 results to clinicians and thereby to their patients. And it will be embedded in standard NHS clinic visits in terms of recruitment at baseline when their blood tests are taken, and also have a couple of additional follow-up visits at 3 and 12 months in person and research telephone clinics at 6 and 15 months, where we'd be able to collect our quality of life and health economic outcomes that will inform the cost effectiveness analysis. We anticipate our primary outcome analysis will be able to be undertaken in year 4, and we'll actually complete the economics analysis at the end of the year 5 towards publication and regulatory submission towards getting it included in a standard of care for NICE if we can show that it is cost effective. The primary outcome will be an increase in the rate of Alzheimer's disease diagnosis in the early versus late disclosure arms by 10%, because our assumption based on our memory clinic audits is that there is a baseline rate of underdiagnosis of Alzheimer's disease in the UK. Blood tests for Alzheimer's disease for ADAPT will be carried out at the Neuroimmunology Clinical Laboratory of the National Hospital for Neurology and Neurosurgery, which is the University College London Hospital's NHS Trust laboratory. And this currently is the centre that receives all of the cerebrospinal fluid samples from across the UK. So it's ripe for being the lab which is the flagship for implementing this blood test. And we hope that in due course, once we can show that it works well in our hands in a study such as this, they would then provide the expertise that could go on to getting the test more disseminated across local laboratories. In terms of the test being interpreted and presented, our interpretation guide will include, as I said, these 2 cut points to assign people as having either high, intermediate, or low probability of Alzheimer's disease. And our interpretation guide will include caveats with respect to renal function and body mass index, whereby we anticipate, for example, that people with higher body mass index will have lower plasma phospho-tau217. There will be some work on the education of clinicians and wider training on the use of this interpretation tool before clinicians are adopted into participating in this trial. The trial will recruit anyone over 50 years who's attending a memory clinic for the first time, and essentially their clinician judges them to possibly have Alzheimer's disease. They should have either mild or moderate dementia at most, rather than severe dementia, because we feel that the blood tests are likely to be most useful in the category of individual who is early in their symptom trajectory. And they would also, the main exclusion criterion is that they should not have any access to any other form of knowing their phospho-tau217 result through a different research study or through participation in a clinical trial. The primary outcome, as I said.
Could I ask a question, or would you take them at the end?
I wonder what the format is. I'm happy to get a question now if you like, if it's brief, or maybe we should reserve them to the end if it's not.
I think I'll be brief. Could you just go back one slide where you had the 4 stages? Sorry, the one before this. Actually, yeah, this one.
This one.
So I was just wondering, on the stage 3, I was just wondering what are we trying to elicit, like the early versus late disclosure, 3 months versus 12-month disclosure of p-tau217,
So it's
Is it
really
to
it's really the primary outcome will be measured at 3 months, which is at that point it's a non-disclosure versus a disclosure. But the reason we've incorporated late disclosure is because we felt on the ethical basis that it would not be ethical to withhold the result from a proportion of individuals in the trial all the way to the end, given that also we're likely to be bringing this test into the clinical sphere soon. This model, I'm coming to it in my later slides as to why we chose this sort of intervention or this sort of assignment, because it has precedence in terms of how the existing biomarker presumed, which is amyloid PET scans, were actually probed in a similar way for their cost effectiveness and their impact on patient-focused outcomes. Is that clear? Yeah.
Yeah, I'll ask at the end if I.
Cool. So just to come back to other secondary outcomes, we'll be looking at people being having their diagnosis changed pre and post the blood test, and the difference in rate of Alzheimer's disease drug prescriptions, that's symptomatic treatments, as well as referral to clinical trials. And if disease-modifying therapies do get approved for implementation in the UK on the NHS in the interim, we would of course also capture that information. The health economic outcomes will be deriving from a combination of the EQ5D5L quality of life instrument and a resource utilization questionnaire, which will look at the utilization of various resources, including medical as well as social care. And the timings of the visits are aiming to reflect NHS practice with research embedded. There will be a maximization of the chance for diverse centres to participate. So we want to get individuals from a widespread geographic area across the UK, and also centres that have increased representation from minority ethnic groups, as well as from those who are from backgrounds of socioeconomic disadvantage. The design of the ADAPT is modeled on that of AMIPAD, which is what I was just referring to in your question, which was a trial that looked at early versus delayed disclosure for amyloid PET results at 3 months versus a year, and looked at improved rate of AD diagnosis as the primary outcome. We've powered the ADAPT study to aim for detecting an increase in 10% in the diagnosis of AD in the intervention arm versus the delayed disclosure arm. And those power calculations enable us to have more than 90% power for detecting that difference at 3 months. If we use 1,100 individuals, and we'll assign them randomly as 1-to-1 between the two arms. The economic outcomes are going to be analysed by our colleagues at the London School of Economics, Martin Knapp, Raphael Wittenberg, and Kate Henderson. And we have oversight and guidance from international advisors, including Michelle Mielke, who will be part of our trial steering committee. The qualitative outcomes are really important as well to capture, because the impact of having a molecular assisted diagnosis in a population that hitherto had no access to such biomarkers will be really important to ascertain whether having more clinician confidence translates into having more patient confidence in diagnosis and their abilities to access the appropriate support. So we'll be looking at the emotional impact of biomarker diagnoses and impact on views about the future amongst the study participants and their study partners, as well as their impact on changes in lifestyle and relationships as a result through focus groups and interviews. And with the clinicians, we'll be looking at impact on diagnostic pathways and how their communication of results and uncertainty about results is influenced by the adoption of this blood biomarker in this study. In terms of the memory services that already have confirmed commitment, we have North London, Kent, Medway, South Wales, but there's been interest from memory services across the entire UK, effectively, including Scotland, and all the way out to the Midlands and into one group in Northern Ireland as well. We'll be looking to submit to ethics in the next 2 weeks, and once we do that, we can start our site initiation reviews to ascertain which sites are likely to be able to support this study. But because it's such a light touch study that involves very little, just effectively the collection of a blood sample and the administration of some questionnaires, either in person or on the phone, we anticipate, in fact, that there'll be a lot of interest. And in fact, so many have come forth without us reaching out that it's really encouraging that we may even recruit earlier than the time frame that we initially set out to do over 2 years. In terms of representativeness, we'll be targeting at least 58% female, at least 15% non-white British or Irish, and at least 25% social grades D and E, and these are guided by memory service audits and UK census data. And we'll be ensuring that we do some unbiased monitoring of baseline characteristics during recruitment and feeding that back to sites so that we can meet those targets without influencing the actual intervention itself. So in summary, the study is a pragmatic study embedded in routine NHS memory clinics. It'll be powered, fully costed. It is powered and fully costed to provide the evidence that will allow us to, if it's shows a positive primary outcome, to adopt this blood test in the standard of care. And it has been co-designed with public co-applicants and extensive PPI input, including a formal PPI group which has just been formed to review the protocol. There is expert review and independent review from a trial steering committee, and it's being handled through the Comprehensive Clinical Trials Unit at UCL. And because the existing NIHR Clinical Research Network infrastructure allows us to reach out to various areas that have capacities to centrifuge, sample, and store blood appropriately, we aim to ensure that although this has a sort of hub and spoke model where the blood samples will be coming into NHN initially, it will also act as a model for setting up local laboratory testing in the future. Once we're able to roll out plasma phospho-tau on the NHS, we hope that this will then be able to be accessed by all patients at the community memory service level who might benefit. And in due course, it may be that this provides a degree of evidence that can take that testing back towards the primary care setting. But we felt it was very important to start with the community memory clinic setting in the first place, given that that is where dementia currently is diagnosed in the UK. So I'd like to acknowledge the entire team on ADAPT and the DRC Wolfson CSF study that I mentioned in that phospho-tau round robin work, as well as our collaborators listed here, and of course the patients who have been very generously giving samples to the DRC's Wolfson CSF study over the last 10 years.